So I'll just quickly recapitulate and hope this doesn't happen too often, because I have a limited, my age, a limited time span. I was pointing out with some rather exaggerated and excessively colourful analogies how complex venoms were, not cocktails, far more complex, and that actually modern techniques are for the first time showing us just how complex they are. And that's great, of course. We want to know what venoms contain. The problem is that we poor clinicians haven't really worked out yet which are the key toxins causing death and disability in our patients. And that's because the so-called clinical phenotype, that is the clinical picture resulting from envenoming by each species, has not been worked out in sufficient detail. And also, we don't have the pathophysiological background to link toxins with clinical effects. So I suppose the point of this talk is about caution before you start targeting very specific toxins or epitopes in venoms to make your exciting new treatments like the recombinant antibodies. We clinicians need to provide you with a little more information. So I think that's where I got to. So the toxins responsible for these clinical effects have not been identified because of lack of pathophysiological studies. And I'd like to illustrate the problem. You may be thinking, well, what's he talking about? We all know neurotoxic, hematotoxic, myotoxic. It's very simple. I'd like to give you some personal examples of surprises from scorpion stings, spider, and snake bites. When I started my interest in envenoming back in the 70s, I was told by knowledgeable people, oh, amongst scorpions, pretty well all scorpions produce the same clinical effect. You know, there are no syndromes, there are no different syndromes. And the classic picture was local pain, autonomic nervous system hyperactivity, the so-called autonomic storm, and predominant cardiovascular effects, epitomized here by the effects of a dangerous Indian scorpion, Hottentotta tamulus, found particularly on the Konkan coast of central India. So local pain, these are effects of autonomic stimulation, salivation, and sweating, and priapism in this little boy. And the cardiovascular effects, horrible looking electrocardiogram and pulmonary edema. But then in 1979, I was reading the Journal of the American Medical Association when I read a really surprising paper. This was from Arvaz in Iran. And the scorpion sting was attributed to a scorpion, which I finally worked out must be Hottentotta salcii. The features were the woman had a swollen face, she developed very severe hemolytic anemia and developed acute kidney injury as a result of the hemolysis. And most surprising of all, extensive local necrosis. This is most unscorpion sting-like, I would say unique almost. So 22 days after the sting, she had this very large area of dermonecrosis. And subsequent inquiries made it quite clear that this sting in Arvaz was caused by Hemiscorpius lepturus, which is in the family Hemiscorpiidae. So don't believe it when people say the only dangerous scorpions are Buthidae. They're not. So this thin-tailed scorpion, which has a limited range in the Middle East, causes a proportion of stings in this southwest region of Iran, near the Iraqi border, and most of the fatalities. And now a lot more is known about its effects. The sting is painless. For a scorpion, that's unusual. Severe dermonecrotic local envenoming, I said, unique. Hemolysis causing acute kidney injury, hyperglycemia, and the excellent Razi Institute antivenoms, extremely potent against most of the species against which they're raised, curiously ineffective in the case of Hemiscorpius lepturus. And here are some examples. I'm assuming that you like gory pictures. Most lay audiences do. But the development, the evolution of extensive dermonecrosis in the arm here, and this little girl who was stung on the face, and most unusual, I can assure you. There are other clinical phenotypes of scorpion sting envenoming. I'd just like to mention briefly the neurotoxic one. In addition to the typical features of autonomic excitation, in the case of stings by the centruroides, they're in the Middle America, the western side of Middle America. Involuntary movements are dominant, with spasms, extraordinary eye movements, opsoclonus and nystagmus, fibrillation of the tongue, and so on. And these involuntary movements may embarrass respiration so that the patient goes into respiratory failure. And then in southern Africa, south and east Africa, parabuthus stings cause hyperesthesia and flaccid paralysis, very like neurotoxic snakebite. So most unusual syndromes, I think, pointing out that more needs to be done investigating scorpion venoms before we assume any particular effects to be the predominant ones. Now, spider venoms, I did put this in to ingratiate myself with Glenn King, who is my chairman. I thought he might give me 5 minutes extra. And I'd like to start with something that possibly he doesn't know, which is very difficult to find with Glenn. Possibly the earliest controlled observation in toxinology was provided by William Harvey, who discovered the circulation of the blood, as you know, De Motu Cordis, 1625. But in 1651, he wrote some exercises concerning the generation of animals, in which he describes this extraordinary experiment. And I'm assuming that probably only one or two of you in the audience understand Latin, but I'm sorry if that's extremely incorrect. But here's the English translation. So William Harvey writes, once, in the interests of experimentation, I pricked my hand with a needle, and then, after rubbing the same needle against a spider's fang, pricked my hand again in a different place. The sight of envenoming puckered into a papule, becoming red hot and inflamed, as if to combat and suppress the noxious effects of the venom. Isn't that beautiful? A simple control experiment in an era when the idea of control experiments was not well known. Well, my most extraordinary experience with spider bites was certainly not a controlled experiment, far from it. This was an unexpected clinical phenotype caused by a bite by a pet old world tarantula spider. Here is the magnificent spider from Borneo, Cereopagubus dorii. Quite a large spider, as you can see. And the patient developed immediate severe pain and swelling. That's not very interesting. But then, shortly afterwards, he started having frequent, in fact, almost continuous, agonizing muscle cramps, each lasting about 30 seconds to 5 minutes, initially in the bitten limb, but becoming generalized. In fact, these were so severe that they prevented his sleeping, eating, and even opening his bowels, the poor chap. And he was unable to receive an intramuscular injection when he was admitted to hospital, because these spasms were provoked by any movement or stimulus, very much like tetanus. And the spasms increased over this period of 4 days and persisted for a total of nearly 10 days, an extraordinary phenomenon. He also had evidence of mild rhabdomyolysis, that's generalized skeletal muscle breakdown. Now moving on to more familiar territory for me, snake bites. And here are some unexpected and/or unexplained clinical phenotypes I've encountered during my work in several different continents. Well, you'll all know about Russell's vipers, the most important venomous, the most challenging venomous snake for my money in South Asia, showing the distribution here of the western Daboia russellii and the eastern Daboia siamensis. And these are the principal causes of death from Russell's viper envenoming. I hope it's not too graphic for you. You can always shut your eyes. Now, I think in the case of the ones in the red box, the bleeding and hemorrhagic phenomena, we've got plenty of toxins acting on blood coagulation, vascular endothelium, and platelets to explain most of these clotting and bleeding phenomena. But what is unexplained are the others. So top left, A, acute kidney injury. What is the cause of renal damage, kidney damage in Russell's viper bite, which is such an important cause of death? And what is the cause of the late developing syndrome of generalized increase in capillary permeability? That's B. One of the features is bulging of the conjunctivae, that's the membrane surrounding the eye and the lining the eyelid, and fluid leaking elsewhere into all the body cavities, and with swelling of the parotid glands. And further, pituitary infarction, another life-threatening complication, virtually unique to Russell's viper, although it was first described in Latin America with the Bothrops. And finally, shock and myocardial toxicity, which is an important cause of death, often an early cause of death from Russell's viper. So you see there are plenty of puzzles still, even in this very well-known Indian snake, which is being studied by so many groups in South Asia, both in the laboratory and at the bedside. Moving now to the Caribbean, the two lesser Antillean Bothrops species, Bothrops lanceolatus from Martinique and Bothrops caribeus from St. Lucia. They produce an extraordinary effect, again, almost unique, which is the cause of death in most cases. So this is in situ development of clots in arteries. In situ is important. It's not emboli. These are not clots carried from elsewhere. These are multifocal in individual organs and are diffusely present in several major vascular beds. So in the brain, in the heart, in the lungs, in the gut, and in the kidneys. And this all happens in the absence of severe coagulopathy. In fact, in some cases, in the absence of any demonstrable coagulopathy. So a real puzzle. Some histopathological evidence has been produced showing that the cause of these in situ clots in arteries is activation of vascular endothelium. And there are these beautiful stains for anti-von Willebrand factor showing dissection of the endothelium from the arterial media, anti-CD31 demonstrating the composition of the clots, which is endothelial cells and fibrin, and finally anti-CD42 showing that these are platelet-rich clots as well. Monospecific Bothrops lanceolatus antivenom, Bothrofab, now made by Ian Cameron, initially proved very effective in preventing or even improving these lethal effects. But recently, the results have been less good, and that's a challenging problem. And you'll notice that this particular pathology has not been adequately fully reproduced in mice. Finally, the genus of kraits in South Asia, you see the extent of the kraits, and these three species, Bungarus candidus, Bungarus multisynchus, and Bungarus niger, have produced some real surprises for the clinical doctors who have to look after the patients, which they then venomed. Now, the principal causes of death, first of all, very well-known causes of death, the descending paralysis. Certainly that kills most patients who are fatally envenomed by kraits. And incidentally, this little child survived with expert care. And I'd like to reassure you that none of the clinical pictures I'm showing you are presented without the explicit permission either of the patient or their guardian, with the understanding they'd be used for educational purposes. But look at these unexpected effects of krait envenoming. Fatal hyponatremia, a fall in serum sodium, probably attributable but not yet confirmed to atrial natriuretic peptide in the venom. And generalized rhabdomyolysis causing fatal acute kidney injury in the case of Bothrops niger. We discovered this in Bangladesh, and Bungarus candidus. See, this patient is passing black urine. It's black because it's muscle pigment, myoglobin. So in conclusion, ladies and gentlemen, why is it so important to define the clinical phenotype of envenoming? I believe that until these clinical phenotypes and fatal effects of envenoming have been defined for medically important species, clinical toxinologists like me will not be able to treat patients optimally because we won't know what we're up against in the venom, which is really important. And the laboratory toxinologist will not know which toxins or epitopes should be targeted by their specific new treatments. I think to define more complete clinical phenotypes, clinicians should strive prospectively to institute detailed protocols for clinical history taking and physical examination, supplemented by laboratory investigations and imaging. In this way, we may build up over the next few years a more complete picture of the clinical phenotype. Thank you for your attention.
Well, I'm glad to say that despite all those interruptions, you finished well ahead of schedule. So we have heaps of time for questions. Who would like to start? I have a question. I was talking to Nick about this morning. I think one of the problems in trying to translate...
Which Nick?
Right. Please Nick, up back here. One of the things we were talking about, the problem in translating some of the laboratory stuff to the clinic, is that there's very few studies on the biodistribution and pharmacokinetics of the toxins after envenomation. It's fine developing an immunoglobulin against a toxin, but if that toxin gets excreted in the first minute after envenomation, you don't care about it. Is there anybody looking at that sort of thing, at how long these things last after envenomation?
Well,
and where they go as well.
Well, in animals, of course, it can be done. There was some nice work by Cassian-Bon's group a decade or two ago.
Is that going to translate those from, say, rodents to a human?
Well, I mean, the pharmacokinetics is terribly important because one of the things that Cassian found was that venom actually redistributed after antivenom treatment. Crudely speaking, it was sucked back into the circulation once you had an avid antibody. This is all controlled by...
Like a reservoir.
Exactly.
Yeah, okay.
And so this could explain one of the explanations for late and recurrent envenoming. The patient seems to be responding to the first dose of antivenom, but particularly if you're using a short half-life antivenom like the FAB fragment antivenoms, like Prof in America, after even a matter of hours, venom, unneutralized venom may be circulating again. I mean, clearly the pharmacokinetics of venom is terribly important because it shows points out one of the major limitations of our only existing and reliable standardized laboratory assays, which is the mouse one. Yeah. Because mixing venom and antivenom before you inject it into the poor mouse ignores all these pharmacokinetic considerations. So I think but until you can find an ethical way of doing pharmacokinetic studies of venom toxins in humans, I'd be glad to hear that. But I really can't imagine it. I think we're going to have to rely on the sort of animal work done by Ismail in Egypt for scorpion toxins, and as a Cassian-Bon, a few other people in snakes.
Yes.